Essential Q&A on Ventral Hernia Management, your comprehensive guide for general surgery residents. Welcome to our podcast, where today we're diving deep into the management of ventral hernias, focusing on what general surgery residents need to know. Pause the video when you hear the word answer to attempt questions. Let's proceed. Anatomy and definitions. Question: what exactly is a ventral hernia? Answer: a ventral hernia refers to any hernia of the anterior abdominal wall, excluding inguinal, femoral, and hiatal hernias. It encompasses umbilical, epigastric, incisional, and spigelian hernias. Question: can you describe the borders of the linea alba? Answer: the linea alba is a midline fibrous structure, running from the xiphoid process to the pubic symphysis. It's formed by the aponeuroses of the external oblique, internal oblique, and transversus abdominis muscles. Question: what is the arcuate line and why is it relevant? Answer: the arcuate line is the lower limit of the posterior rectus sheath, located below the umbilicus, where all aponeuroses pass anterior to the rectus muscles. Question: what defines a spigelian hernia? Answer: a spigelian hernia occurs through the spigelian fascia at the lateral border of the rectus muscle, most commonly below the arcuate line. Question: in laparoscopic hernia repair, what is the triangle of doom? Answer: the triangle of doom is an area bounded by the vas deferens medially and testicular vessels laterally. It contains the external iliac artery and vein. Caution is required here to avoid vascular injury. Classification and risk factors. Question: how are ventral hernias classified by size? Answer: small hernias are less than 2 cm, medium are 2 to 4 cm, large are over 4 cm, and giant hernias exceed 10 cm or involve loss of domain. Question: what does the European Hernia Society, EHS classification entail? Answer: the EHS system classifies hernias based on location, midline, lateral, or lumbar, and size. W1 is less than 4 cm, W2 is 4 to 10 cm, and W3 is greater than 10 cm. Question: what is loss of domain in ventral hernias? Answer: loss of domain is when more than 20% of the abdominal contents are herniated, making reduction challenging and increasing the risk of abdominal compartment syndrome. Question: what modifiable risk factors affect hernia recurrence? Answer: risk factors include obesity, smoking, diabetes, malnutrition, chronic cough, and steroid use. Question: what are the recurrence rates after primary suture repair? Answer: incisional hernia recurrence after suture repair is 30 to 50%. Mesh repair lowers this to 10 to 20%. Preoperative evaluation. Question: what imaging modalities are preferred for complex hernias? Answer: CT scans are the gold standard for assessing size, contents, and loss of domain, while ultrasound may help with smaller hernias. Question: when is preoperative botulinum toxin useful? Answer: for giant hernias, botulinum toxin can be injected about 4 weeks preoperatively to relax lateral abdominal muscles, making fascial closure easier. Question: could you explain component separation and when it is used? Answer: component separation involves releasing the external oblique or transversus abdominis muscles to mobilize the fascia for midline closure. It's reserved for large hernias. Question: how do you preoperatively assess loss of domain? Answer: preoperative CT volumetric analysis is key. If the hernia sac volume to abdominal cavity volume ratio exceeds 20%, it's considered loss of domain. Question: what lab tests are important before hernia repair? Answer: standard labs include complete blood count, basic metabolic panel, HbA1c, for diabetics, and albumin if malnutrition is suspected. Surgical techniques. Question: what are the principal mesh positions during hernia repair? Answer: mesh can be placed as an onlay, above the fascia, sublay, behind the rectus muscle, the gold standard for open repair, or underlay, intraperitoneal, common in laparoscopic repair. Question: in what scenarios is primary suture repair appropriate? Answer: it's reserved for small, clean, low-tension hernias, such as umbilical hernias in infants. Question: what are the benefits of laparoscopic intraperitoneal onlay mesh repair? Answer: laparoscopic intraperitoneal onlay mesh repair offers lower surgical site infection rates and faster recovery, but can have higher seroma and recurrence rates compared to open sublay repair. Question: what mesh types are used in contaminated surgical fields? Answer: biologic meshes, such as acellular dermal matrix or resorbable synthetics, are preferred in contaminated fields, avoiding permanent synthetics. Question. Briefly, what is TAR? Answer. Transversus abdominis release. TAR is a posterior component separation technique that divides the transversus muscle to allow medial advancement of the rectus complex. Complications and management. Question. What is the most common complication after ventral hernia repair? Answer. Seroma formation, which occurs in 30 to 50% of cases and often resolves on its own. Question. How should a persistent seroma be managed? Answer. If it lasts more than 8 weeks and is symptomatic, aspiration may be performed. Early drainage is generally avoided due to infection risk. Question. What are the signs of mesh infection? Answer. Symptoms include erythema, fever, purulent drainage, and non-healing wounds, often confirmed with CT imaging. Question. When is mesh explantation necessary? Answer. Mesh removal is required for chronic infection, fistula formation, or erosion into the viscera. Question. What is the risk of bowel injury during laparoscopic repair? Answer. The risk is about 1 to 2%. If enterotomy occurs, conversion to open surgery may be warranted. Special scenarios. Question. How is an incarcerated hernia managed? Answer. Emergent surgery is needed if strangulation is suspected. Otherwise, elective repair can be scheduled after reduction. Question. What does the term Swiss cheese abdomen mean? Answer. It refers to multiple prior incisions with limited intact fascia, often requiring complex reconstruction. Question. How is a peristomal hernia addressed? Answer. Mesh reinforcement, via Sablé or the Sugar-Baker technique, is typical, sometimes with stoma relocation. Question. When is paniculectomy performed with hernia repair? Answer. In obese patients, performing paniculectomy during hernia repair reduces wound complications. Question. What is the role of negative pressure therapy? Answer. Negative pressure therapy lowers surgical site infection rates in high-risk wounds, such as those in open or contaminated repairs. Advanced surgical approaches. Question. What is the Chevreul technique? Answer. This is an open repair using retromuscular mesh and fascial relaxing incisions in the external oblique aponeurosis to reduce tension. Question. How should recurrent hernias be approached? Answer. Evaluate prior repairs and mesh position. Consider an alternative technique, and use biologic mesh if infection is present. Question. What advantages does robotic hernia repair offer? Answer. Robotic repair blends minimally invasive and open techniques, suitable for complex cases but comes with higher costs. Question. How is mesh fixation done in laparoscopic intraperitoneal onlay mesh repair? Answer. Mesh is secured with non-absorbable transfascial sutures at 4 to 5 cm intervals and tacks between sutures. Question. What complications are associated with transfascial sutures? Answer. Risks include chronic pain, nerve entrapment, bleeding, and bowel injury. Question. How is chronic pain managed post-hernia repair? Answer. Options include NSAIDs, gabapentin, nerve blocks, and mesh or tack removal if pain is refractory. Question. What is a bridged repair and why avoid it? Answer. Bridged repairs use mesh to span the defect without closing the fascia. They have high recurrence rates and are generally avoided. Question. How are trocar site hernias managed? Answer. These require laparoscopic reduction and mesh repair. Closing fascial defects over 10 mm helps prevent occurrence. Question. What is the ACSNSQIP risk calculator? Answer. The American College of Surgeons National Surgical Quality Improvement Program is a tool to predict postoperative complications based on patient comorbidities. Question. How do you distinguish diastasis recti from a true hernia? Answer. Diastasis is a widened linea alba without a fascial defect. Hernias have a palpable defect or protrusion. Preoperative optimization. Question. What is the role of preoperative weight loss? Answer. Achieving a BMI below 35 reduces recurrence and wound complications. Bariatric surgery is considered for those with BMI over 40. Question. How are hernias managed in cirrhotic patients? Answer. Surgery is reserved for compensated cirrhosis. Child-Pugh A. Mesh is avoided if ascites is present. Question. What is the coffee bean sign on CT? Answer. It indicates dilated bowel loops in a hernia sac, suggesting incarceration or strangulation. Question. What is a Richter's hernia and how is it diagnosed? Answer. It involves partial bowel wall entrapment, diagnosed via CT, and may not show classic symptoms until strangulation occurs. Question. What about intraperitoneal tissue plasminogen activator for adhesions? Answer. It's experimental. While it may reduce adhesions in reoperative cases, it also poses a bleeding risk. Complications and revisions. Question. How is a mesh fistula treated? Answer. Surgical removal of the mesh and bowel resection if necessary, followed by staged repair, often with biologic mesh. Question. What is the Rives-Stoppa technique? Answer. It is considered the gold standard for open repair, retrorectus mesh placement with fascial closure. Question. How are lateral hernias repaired? Answer. Open primary repair with or without mesh, or laparoscopic intraperitoneal onlay mesh repair, are valid options. Question. Does fibrin glue help prevent ceremus? Answer. Evidence is limited. It may reduce seroma volume but not the incidence. Question. How can recurrent incisional hernias be avoided? Answer. Tension-free fascial closure with mesh reinforcement and optimization of comorbidities is crucial. Special scenarios and innovations. Question. What is the sandwich technique? Answer. It involves both preperitoneal and onlay mesh placement, but isn't commonly used due to high infection risk. Question. How are hernias managed in pregnancy? Answer. Hernias are monitored unless incarcerated. Repair is generally performed postpartum. Question. What is preoperative pneumoperitoneum? Answer. Gradual insufflation of the abdomen before surgery helps expand abdominal domain for giant hernias. Question. How are traumatic abdominal wall hernias handled? Answer. Prompt mesh reinforcement, unless the field is contaminated, is recommended. These injuries often involve intra-abdominal organs. Question. What is a ghost mesh infection? Answer. This refers to chronic infection with mesh resorption, leaving only inflammatory tissue behind. Mesh and biologics. Question. How is chronic mesh infection diagnosed? Answer. Imaging, often CT or PET-CT, reveals fluid collections and sinus tracts, sometimes requiring mesh removal. Question. What role does MRI play? Answer. MRI can evaluate mesh infections and muscle atrophy, especially when CT is inconclusive. Question. How should immunocompromised patients be managed? Answer. Non-mesh or biologic mesh repairs are preferred due to high risk of infection and recurrence. Question. What is the on-step technique? Answer. It is a preperitoneal mesh placement method for inguinal hernias and less commonly used for ventral hernias. Question. How is recurrent peristomal hernia prevented? Answer. Employing sugar baker or keyhole mesh techniques during initial stoma creation reduces recurrence. Emerging concepts and controversies. Question. What's the evidence for prophylactic mesh at stoma creation? Answer. High-level evidence shows it reduces peristomal hernia rates. Question. How are hernias managed in the elderly over 80? Answer. Minimally invasive techniques are prioritized, balancing surgical risk against the option for watchful waiting. Question. What is the shoelace technique? Answer. It uses a continuous, slowly absorbable suture for fascial closure. Question. How are hernias managed in patients with refractory ascites? Answer. Ascites control is essential before repair. Mesh is generally avoided if ascites cannot be managed. Question. Why optimize preoperative albumin? Answer. Albumin levels above 3.0 gdl are associated with fewer wound complications. Key controversies. Question. What is the hybrid technique in hernia repair? Answer. It combines laparoscopic adhesiolysis with open sublay mesh placement. Question. What is the debate between sublay and onlay mesh placement? Answer. Sublay offers lower recurrence but requires more dissection. Onlay is technically simpler but has a higher infection risk. Question. How does laparoscopic compare to robotic repair? Answer. Robotic repair allows laparoscopic sublay mesh placement but at higher cost. Question. What does the future hold for hernia repair? Answer. Innovations include bioactive meshes, 3D printed scaffolds, and stem cell integration. Question. What is the most important predictor of long-term hernia repair success? Answer. Achieving tension-free fascial closure with mesh reinforcement. Thank you for joining us. We hope this comprehensive Q&A sheds light on the complex landscape of ventral hernia management for surgery residents and practitioners alike. Stay tuned for more high-yield surgical discussions in our next episode.